Can you see my screen there?
Yes, we can.
Perfect. Okay. So thanks very much for the introduction, Selena. I'm Stuart. It's a pleasure to be teaching you guys. So there's quite a lot to cover, so I'm gonna get cracking. But just wanted to say that if you have any questions during the talk, please feel free to unmute your mics and just ask, or hopefully if time allows, there'll be an opportunity for questions at the end as well. So just an overview of the talk. We're going to talk about acute abdomen. So we'll cover what acute abdomen is. We'll go over the definition, tell you about focused history taking and focused examination to try and find out the cause of the patient's symptom. How to interpret deranged vital signs. So how these can give you a clue as to what is going on. We'll talk about the important causes of acute abdomen. So some of these are benign, some are more serious, and some are life-threatening. And what investigations to do to help you to differentiate between these different causes. We'll also talk about the first-line treatment of these important causes and which teams to refer the patients to. So I'm quite keen on learning definitions. I think this is very useful, both in terms of your communication with patients and also with your colleagues. So just for example, often patients come to hospital having already seen a doctor in the community, or they will have spoken to a paramedic if they came by ambulance. And this might have put an idea in their head, like a paramedic might say to a patient, I think you might be septic. If you're confident with the definition of sepsis, then you can potentially reassure the patient that although I think you do have an infection, you're not systemically unwell, therefore you're not septic, and I'm happy to send you home with tablet antibiotics. And similarly with this definition of acute abdomen, if you use it appropriately, it's a succinct way of conveying to other medical professionals, so for example, the surgical team, that you're concerned about this patient, and the surgical doctor is likely to be concerned as well if you use this terminology. So what is the definition? So it's any patient that presents with acute severe abdominal pain, which leads them to present to hospital within hours. So why is it an important topic? Well, it's a common presentation to the emergency department, and as we'll go on to find out in the next few slides, there may be underlying life-threatening pathology. There's a wide range of differentials, and this presents a diagnostic challenge. But I quite enjoy seeing these patients because it does make you think, and you have to go through different systems, and your interpretation of the history, the exam, and ordering investigations takes a bit more brain power than a lot of other presentations. So I don't know if you guys are familiar with this mnemonic, but this is one which is quite commonly used at or taught in UK med schools, which is SCRITARS, but you might have a different one for taking history. But just to go through SCRITARS, so if you ask a patient initially, where is the site of the pain? And I find it quite useful to ask them to point with one finger as to where they feel the pain, because if they use their hand and they wave it around their abdomen, then it can not be very useful information. So just ask them, point with one finger as to where it hurts you the most. You need to ask the patient, does the pain radiate and has the pain moved? So for example, classically in appendicitis, the pain starts centrally and then moves to the right iliac fossa. You need to ask them about the quality of the pain. So for example, is it sharp? Is it burning? Is it dull? Especially with abdominal pain, you need to identify, is it colicky or is it constant? Colicky pain suggests pathology in an area where peristalsis occurs. So for example, with ureteric stones or with bowel obstruction. Need to ask about intensity. We tend to ask patients to rate their pain on a 1 to 10 scale. Now, this is quite subjective, but it's useful in the sense that if you give some intervention, so if you give some analgesia, you can then ask the patient after the analgesia, how is your pain now? So even though it's a subjective scale, there hopefully will be some improvement in how they rate their pain after you've given some pain relief. In patients that don't communicate well for different reasons, you can use some other tools. So for patients with advanced dementia, they're not going to be able to give you a 1 to 10 rating of their pain, but you can use a tool like the Abbey pain scale. It's important to ask, was the pain maximally severe at onset, and not just with acute abdomen, but generally with medicine. Pain that is at maximal onset when it first comes on is generally concerning. So you might get this with a bowel perforation, with a subarachnoid hemorrhage, with aortic dissection. So life-threatening problems tend to cause maximum pain, which comes on very quickly. Need to ask about timing. So when did the pain start? Is it getting better? Is it getting worse? Is it staying the same? Is there any variation with different times of the day? So just for example, epigastric pain, which occurs during the night, tends to suggest gastric esophageal reflux disease, because when the patient lies horizontally, the pain and the symptoms worsen. Have they had any previous episodes? Need to ask about aggravating factors. So generally, again, not just with regard to the abdomen, pain worse with movement suggests a musculoskeletal problem, so that can be quite reassuring. Pain after eating may suggest biliary colic or cholecystitis. Ask about relieving factors. So an improvement with mild over-the-counter analgesia like paracetamol is quite reassuring. You wouldn't expect to get that with really severe abdominal pathology. Pain may improve after vomiting with problems like bowel obstruction. So then we move on to asking about secondary symptoms, and the ones applicable to the abdominal system are fevers. So fever is suggestive of infection, but just note that isn't the only cause. Anorexia is common in children with appendicitis, so this is a complete loss of appetite. Need to ask about nausea and vomiting. So this could be just due to pain, but patients that vomit excessively, maybe you think about bowel obstruction. Constipation alone can cause severe pain, but not opening your bowels and not passing any flatus, again, is suggestive of bowel obstruction. Diarrhea might be due to gastroenteritis, and a PR bleed could be due to hemorrhoids, whereas blood mixed in, separate to the stool may be due to GI malignancy or inflammatory bowel disease. So the patient might have a decreased urine output if they're systemically unwell. So if they're septic and hypovolemic, this might affect how much urine they're producing, and this doesn't necessarily indicate a problem of the urinary tract. Not weeing at all might be due to acute urinary retention, which is a cause of severe acute abdominal pain in itself. And pain and frequency with passing urine might be a sign of urine infection or pyelonephritis. Hematuria is often seen with ureteric stones. So weight loss is really important to ask a patient about. Significant weight loss is generally considered to be more than 5% of a patient's body weight over at least a 6-month period. So if this has happened unintentionally, then you need to think about malignancy. All females of a childbearing age, you need to ask about PV symptoms and when their last period was. And have they had any previous abdominal surgery or gynae surgery? So this is important because any surgery in that area can cause adhesions, which is scar tissue. And then this can predispose the patient to further problems like pain and obstruction. So examination is something you'll be quite familiar with, and it's a similar approach to examining any other part of the body. So you need to look initially. I quite like starting at the hands, moving to the face, then onto the chest, and then to the abdomen, because you go in a set order, and that means you tend not to miss anything. So you look at the hands for systemic signs like clubbing, then move up to look at the face, check if there's any jaundice. So you look at the sclera, the white of the eyes, and under the tongue. You can then look at the chest. Sometimes you can get signs of liver disease like spider nevi. And finally, look at the abdomen. So the patient might have a surgical scar from a previous procedure. They could have a stoma. The abdomen could look grossly very distended. Sometimes you can get Cullen's and Gray-Turner's sign, which can be a sign of intra-abdominal bleeding. So you then listen to the abdomen. So you need to auscultate the chest and the heart as well. There might be excessive bowel sounds with a flare-up of inflammatory bowel disease or with gastroenteritis, or absent or very scant bowel sounds are found in obstruction. So you then move on to feel. So feel the hands initially. If they're very cold and there's a prolonged central capillary field, then the patient is potentially shut down, and that requires urgent management, which we'll move on to in later slides. A weak rapid radial pulse is also concerning for the same reasons. You need to make sure that the patient's lying as flat as possible with their neck relaxed backwards, because this will mean that their abdominal muscles are relaxed, and this is how to examine the abdomen properly. Try and warm your hands up before you start examining them, because patients will tense up with really cold hands, and this impairs your examination. And if the patient's told you that it really hurts in one part of that abdomen, start feeling in the opposite side, and this will give you maximal information. You can split the abdomen up into 9 sections or 6 sections or 4, depending on your preference, but just work your way around those different sections and ascertain what part of the abdomen is tender. You need to palpate the renal angles, and I would advise you get a chaperone, but you need to examine the groin for any hernia or any masses, especially in males. The testes are really important to be examined with lower abdominal pain, and sometimes this pain can be the only sign of a testicular pathology like a torsion. So you need to decide if that abdomen is peritonitic or not. So this means that the abdomen feels firm due to involuntary guarding, and this is quite concerning. This warrants an urgent surgical review. Need to assess for rebound tenderness. So if the patient feels a sudden sharp pain when you take your hand away, this suggests peritoneal irritation, which again is very concerning. Percussion is quite useful. So this helps you assess for a distended bladder, for example. And a PR exam is often warranted with acute abdominal pain. So you need to verbally consent the patient. There should be a chaperone present, and you need to document that you've had a chaperone there and document your findings clearly. So for doing the PR exam, as I'm sure you guys know, you need to look for external abnormalities like an anal fissure, external hemorrhoids. And then upon actually doing the PR, you need to see if there's any frank blood or any melena. You might feel that they're constipated, and you could possibly feel a mass like a rectal tumor. So it's a very useful examination to do. So thinking about the patient's vital signs, these are the common abnormalities you might expect in a patient with acute abdomen, and just going to briefly go over as general rules of thumb how to interpret these. So if a patient's very hypertensive, this might just be due to pain or the anxiety of having to come to the emergency department, so it's potentially not too worrying. So you can review this again after you've given them adequate analgesia and some reassurance. Low blood pressure, however, is more concerning. So generally speaking, a mean arterial pressure under 65 or a systolic under 90 is defined as hypotension. Now, this could be due to sepsis causing hypovolemic shock. It could be because the patient's very dehydrated due to insensible fluid losses. It could be due to hemorrhagic shock, for example, due to a ruptured AAA. Regardless, you need to urgently assess and treat the patient, and we'll cover that in the next few slides. One thing to check is that the blood pressure cuff isn't too big for the patient, because this will falsely give you a low blood pressure reading. So tachycardia, similar to high blood pressure, this could just be due to pain or anxiety. But I wouldn't make that assumption, and it more concerningly could be as a reflex to the patient being hypotensive or on the verge of dropping their blood pressure. So it's an earlier sign of shock than hypotension. So you need to obtain a 12-lead ECG to check the patient doesn't have a tachyarrhythmia rather than just sinus tachycardia. And you need to do this quickly if the patient's very tachycardic. So over about 120, I'd get a urgent ECG to make sure the patient's not in fast AF or SVT, for example. So bradycardia, this might be normal for a patient who's young and fit. You could ask the patient if they take beta blockers, and we'll come on to one of the causes of acute abdomen, which is an inferior MI. So this is a pathological cause of a bradycardia. So hypoxia could occur due to the patient not being able to ventilate properly. So if they've got raised intra-abdominal pressure for any reason, this can cause some splinting of their diaphragm, which impairs ventilation. If the patient's peripherally shut down because they're shocked, then the saturation probe is unreliable because they've got cold extremities. So the low saturation reading might not be accurate. If you're unable to ascertain whether the patient's hypoxic or not, it's a good idea to get an ABG, and then you'll get an accurate assessment of the patient's oxygen level in their blood. This could be due to an acute respiratory pathology. So one cause of acute abdomen is a lower lobe pneumonia. So if the patient is hypoxic with upper abdominal pain, then this should be higher up your list of differential diagnoses. Or the patient could be chronically hypoxic due to COPD, pulmonary fibrosis, etc. So tachypnea, if the patient's breathing quickly, again, could be due to pain and anxiety, or it could be because they're systemically unwell. And if the patient's pyrexic, this is essentially infection until proven otherwise. So it could be due to any intra-abdominal infection, whether this is biliary sepsis, gastroenteritis, pyelonephritis, but also consider infection elsewhere. So like I just mentioned, sometimes lower lobe pneumonia can cause abdominal pain. You can also get fevers due to chronic inflammatory conditions like rheumatoid arthritis or malignancy, but before thinking about these things, you need to exclude infection. So I know I'm just kind of plowing through the slides at the moment. So if anybody's got any questions, like I mentioned before, please just speak up and feel free to interrupt me. So thinking about the causes of acute abdomen, I like to split these up into different systems, and the kind of most logical one to start with is the GI system. So a bowel obstruction or bowel perforation can cause acute abdominal pain. Constipation is a more benign and obviously a lot less worrying cause of pain, but this is a diagnosis of exclusion. So you need to exclude all of the other worrying causes before you can say that this severe pain is due to constipation. It could be due to biliary pathology, whether that's biliary colic, cholecystitis, or ascending cholangitis, or any abdominal abscess. It could be due to ischemic bowel, pancreatitis, appendicitis, and a whole load of other things. So we'll cover a number of these in more detail soon. The second system to think about is urological. So the pain could be due to ureteric stones. Note that I say ureteric stones rather than kidney stones, because kidney stones are stones within the kidney, as the name suggests, and these don't cause pain and these don't cause a problem unless they drop down into the ureter. Ureteric stones are a problem because they potentially cause obstruction of the urinary tract, and they cause pain because of the peristalsis of the ureter. Acute urinary retention is another cause. And again, this is acute retention, not just urinary retention. So some older males with large prostates will go into chronic retention, which happens over a period of weeks or months, and this doesn't cause acute pain. Pyelonephritis, and like I mentioned before, testicular torsion is one of the serious urgent causes of acute abdomen. So this is why we always need to examine the testicles in a male with acute abdominal pain. So the cardiovascular causes of acute abdomen are all quite scary and quite serious. So an inferior MI can cause upper abdominal pain. If you've got concerns for an MI, an ECG alone doesn't exclude the diagnosis. So you can have a non-ST elevation MI with a completely normal looking ECG. So if you've got concerns, you need to check a troponin as well as looking at the ECG. A AAA, which is abdominal aortic aneurysm, causes lower abdominal pain. So 90% of AAAs occur below the level of the kidneys, so that's about L2. And this can be painful if the aneurysm is just big, or it causes a lot of pain if it's ruptured. And a ruptured AAA is got a very high mortality and requires urgent surgical intervention. And that's similar to an aortic dissection. So this presents with classically chest pain, which is like a tearing, sharp, ripping sensation that goes through to the back between the shoulder blades. But the patient might describe it as upper abdominal or epigastric pain. But if you have concerns for this, you need to do urgent imaging of the aorta. So you need to get a CT aortogram. And there's gynecological causes of acute abdomen. So a ruptured ectopic pregnancy is very serious. This is one of the causes that we'll talk about. Ovarian torsion and ruptured ovarian cyst also cause acute pain. But these are less urgent, and these tend not to have a high mortality. So the ruptured ectopic is the really important cause that you need to exclude with a female of childbearing age. Then, like I've mentioned already, a lower lobe pneumonia can cause upper abdominal pain. So whether this is in the right upper quadrant or the left upper quadrant, depending on which lung is affected, this is an important differential to consider. So you always need to auscultate the chest, ask the patient about whether they've had any symptoms of pneumonia. So have they had any fever, any cough, any breathlessness? So in terms of your general workup for a patient with acute abdominal pain, like every unwell patient, you need to do an A to E assessment. Urine dip is essential. So with this, we can look for signs of a urine infection. If there's blood in the urine, this can be indicative of a ureteric stone, like I said before. It's important to bear in mind that you can get false positives with a urine dip, and this is especially common in the older population. So at least at my hospital, our microbiologists recommend that we don't perform a urine dip in anybody over the age of about 60 or 65. And in these patients, if they've got signs and symptoms of a urine infection, then you treat. And if you're not sure, you send off a midstream urine for culture. And if that shows evidence of infection, at that point you treat. So just a word of caution about interpreting a urine dip. You need to check a HCG in all females of childbearing age. And this can be done by urine test, or you can add this to your blood test results. But obviously this takes a bit longer than the urine test. If you send off your routine bloods, it's good to get a blood gas, whether this is venous or arterial, because with this you'll get a lactate and other parameters that you can't get from the lab bloods. So lactate's very useful with abdominal pain. A raised lactate is not specific, but it is concerning. Consider adding an amylase, or if your hospital does lipase, these tests are useful for pancreatitis. And if the patient is possibly septic, then you should send blood cultures as well. In every patient, no matter what they come to hospital with, we should check a BM. And we should get an ECG for various reasons, some of which have already been mentioned, like acute MI being one of the causes of acute abdomen. Chest X-ray is a good idea, so you can look for a pneumonia with this, and an erect chest X-ray is even better because you potentially could see an early sign of air within the abdominal cavity. So you may see pneumoperitoneum. Having said that, an erect chest X-ray which doesn't show pneumoperitoneum doesn't exclude a perforation. So if you suspect perforation, an erect chest X-ray isn't the investigation of choice. But if the patient's going for X-ray anyway, you might as well do an erect chest X-ray because it might give you an earlier clue as to this pathology. So a FAST scan is a bedside ultrasound scan that we sometimes do in A&E. This tends to be done for hemodynamically unstable patients, which isn't really the focus of this talk. We can do bedside aortic ultrasound, so you can look down the abdominal aorta and see if it's widened at any point, which can be indicative of a AAA. And we can also do bladder scans, which is useful if you suspect the patient has got retention. So we'll go through how to manage and investigate the important causes of acute abdomen, but CT is often the investigation of choice. So this can be abbreviated to CT-AP, which is CT abdomen and pelvis. And you may or may not do this with contrast, depending on what you're looking for. So your general management of any unwell patient is to get good IV access, which means 2 large bore cannula. You can give some IV fluids initially, so you can give a bolus of 500 mils to a litre if the patient is shocked, and then reassess to make sure that the patient's odds and clinical state are improving. Then if you think the patient is dehydrated and they've got ongoing insensible losses, you need to not just give them maintenance fluid, but probably a bit more to account for this fluid deficit. If you think the patient's got a potential surgical problem, then making them nil by mouth is an important part of management until the surgeons say otherwise. And need to give the patient good analgesia for multiple reasons, mainly for ethical reasons, but this also allows you to perform investigations more easily and aids with your examination of the patient. Again, if you think a patient potentially is going to need surgery, you need to send group and save because they might need blood transfusion if they go for theatre. And a catheter is a good idea if a patient is systemically unwell, because this is a good way of monitoring the end organ perfusion. So we're just going to start to go through some of these important causes of abdominal pain now. So first of all, talk about peptic ulcers. So the management of this, if this presents with a shocked patient, so whether the patient's got a perforation or whether they've got a severe upper GI bleed, as just mentioned, you need to get good IV access and give fluid boluses, plus or minus blood if the patient is bleeding. If they're hemodynamically unstable and you suspect a severe upper GI bleed, you need to put out a major hemorrhage call, which means that the transfusion part of your hospital gets blood and blood products ready, which initially might not be group and save. This would just be O negative blood. You need to perform a PR exam in patients where you think that they've got upper GI bleeding, and you're looking for melena. And investigation-wise, you need to check their hemoglobin, and you should also look at their urea level. So urea goes up with upper GI bleeding because it basically is the equivalent of eating a really high protein meal. And one of the breakdown products of protein is urea. So we give IV PPIs for patients with peptic ulcers, and might be different in other countries, but we tend to give pantoprazole 40 milligrams IV. There's no evidence for tranexamic acid in patients with upper GI bleeding, interestingly, because with most other causes of bleeding in the body, we give tranexamic acid, but no evidence in an upper GI bleed. And in fact, this makes you more prone to clot, so it's not without harm. So there's no evidence of benefit, and if you give a patient TXA, then they're at higher risk of thrombotic events. But you do need to check if the patient's on anticoagulation, whether that's NOAC or warfarin, and reverse this as appropriate. If you suspect perforation, then an urgent surgical review is needed. If the patient's stable, they need a CT scan. If the patient has got an upper GI bleed, then you can calculate the Blatchford score. And these patients tend to go under the medical team because this is deemed a gastro problem. So it's the gastroenterologist that would perform an urgent endoscopy if needed. So this is a screenshot from MD Calc, which you can access from your phones. You can download the app. It's really useful. So it's a very quick, user-friendly tool to find all kinds of useful scoring systems. But this is the Blatchford score. So you enter the details as below. You need the blood results here, so you need a hemoglobin, and the BUN, you can see the second row is the serum urea level. So once you put all of these variables in, you get a score, and this indicates the risk of mortality from this patient's upper GI bleed. So this is very useful for your own management, and when you speak to the medical team, or if you speak to the on-call endoscopist, you can communicate the Blatchford score, and this helps them determine how urgently they need to intervene. So the second thing we're going to look at is ischemic bowel. So this essentially is an ischemic event leading to necrosis of one part of the bowel. And it's similar to other ischemic events in the body. So whether this is an ischemic limb or an ischemic stroke or myocardial infarction, the risk factors and the causes are similar. So ischemic bowel generally is either due to atherosclerosis with plaque rupture or due to an embolic event. This should be suspected in older patients with abdominal pain, and they almost always have a disproportionately raised lactate. So when there's anaerobic metabolism in the body, one of the byproducts is lactate. And this ischemic bowel also makes the patient systemically unwell. So not just in the bowel, but also in their peripheries. If they're becoming shocked and shut down, there'll be anaerobic metabolism. And this causes them to have a very high lactate, disproportionate often to how the patient otherwise presents. Sometimes they don't present with abdominal pain at all. Sometimes the abdomen isn't tender at all on examination, but this very high lactate in an older patient is concerning for this pathology. As the disease progresses, this dead part of bowel becomes septic, and the patient then becomes peritonitic and systemically very unwell. So a CT angiogram of the abdomen is the investigation of choice, and the patient needs an urgent surgical review. Now, because this dead bit of bowel eventually causes the patient to become septic, the dead bit of bowel has to be removed urgently, or else the patient will die. This isn't a problem which can be treated with IV antibiotics alone. And often this is a terminal event in older, frail patients, because if they're not fit for a general anaesthetic, or if they don't wish to undergo a general anaesthetic and a major operation, then this is a acutely life-limiting event. And the mortality of ischemic bowel is over 50% even with treatment. So it's a really serious problem. Need to keep the patient nil by mouth, like we've mentioned before. Give them IV fluids, because even if they're not shocked now, they'll be losing fluid through this dead section of bowel. Cover with IV antibiotics and make sure they've got adequate analgesia. If the patient isn't for surgery, then you need to think about anticipatory medications for symptom control. We refer all of these patients to our surgical team, whether they're for surgical intervention or not. And there's a few reasons for this. So just for example, if some family members aren't present within the emergency department when the decision's made, either by the medical staff or by the patient, or by their next of kin who advocates for them, that they're not fit or don't want to go for surgery, maybe other relatives come later that day or the following day, and they might be very distressed by this decision. And if the patient's on a medical ward, for example, then the medical team aren't going to be able to provide them with the right information about the pros and cons of surgery. So this is just one reason why the most appropriate place to be is on the surgical ward, even if the patients aren't going to theatre. So next, we're going to talk about bowel obstruction. So the classical presentation is colicky abdominal pain because of the peristalsis of the bowel, abdominal distension, vomiting, and unable to open the bowels and unable to pass flatus. So you can remember the small bowel causes of obstruction with HAT, which stands for hernias, adhesions, and tumours, and the large bowel causes with DVT. So the three most common causes of large bowel obstruction are diverticular disease, volvulus, which is twisting of the bowel, and again, tumours. So if the patient's actively vomiting, then you need to put in a wide bore NG tube and leave this open to free drainage. So this essentially empties the contents from the stomach and reduces the risk of aspiration. You need to give IV fluids, analgesia, and if an antiemetic is needed, cyclizine tends to be preferred. One thing to note with cyclizine is, especially if given quickly, it can drop a patient's blood pressure. So if they're unstable, I'd be cautious about giving this. CT abdomen is the investigation of choice. So abdominal X-ray is really out of favour, especially in the context of bowel obstruction. So it's not very sensitive at all for bowel obstruction. So similar to what I said about erect chest X-ray and bowel perforation, a normal abdominal X-ray, which doesn't show dilated bowel, doesn't exclude obstruction. So therefore it doesn't serve much purpose. So if you suspect obstruction, you need to do a CT scan, and these patients go to the surgical team. So acute appendicitis, this classically starts with periumbilical pain, and then it moves on to the right iliac fossa. So this is because initially let me think which way around it is, the parietal peritoneum is inflamed, and then as the condition progresses, the visceral peritoneum becomes inflamed. So your brain initially can't locate exactly where the source of the inflammation is, but when the visceral peritoneum is inflamed, the brain realizes that the problem is down in the right iliac fossa. So anorexia is a common symptom in children, and it's really useful in children, especially in those who you think have a low likelihood of appendicitis, and you're thinking that you might be able to discharge them, to ask them to stand up from the couch and get them to jump up and down. If they're able to do that and that doesn't cause a lot of pain, then that's very reassuring, because an inflamed appendix will be rubbing them and up and down while they're jumping, and that shouldn't be something that they're able to do. Rovsing sign is useful, and it's commonly seen actually. So this is when you palpate in the left iliac fossa, it causes them pain in the right iliac fossa. And this is because the peritoneum covers all of the abdominal contents. So when you press on the left side, this cover stretches over the right side, which touches the inflamed appendix and causes pain. You might see on the blood results that the white cells and the CRP are elevated, but there's poor sensitivity and specificity here. So a patient with normal white cells and normal CRP doesn't mean they don't have acute appendicitis, especially in the early stages. So a bit of a recurring theme with the management approach. So patients should be null by mouth. You give them IV fluids, analgesia. Don't always need to give these patients IV antibiotics. Tends to be reserved only if you suspect perforation. So if the patient's got signs of peritonism, if they've got rebound tenderness, or if they're systemically unwell and septic, then I would give IV antibiotics. And if they've got pain alone, which is suspicious for appendicitis, but they're otherwise well, then I would hold off and the surgical team will decide.
Sorry,
Imaging
I'm so sorry, Dr. Foster. I had a quick question.
Of course.
Sometimes when a kid is, or anyone actually is in pain, they can get quite defensive, or their stomach or their abdomen basically tenses up because they can kind of sense that something's going to hurt. How reliable of a sign would that be for perforation? Does it depend on like anyone's tolerance of pain, or is it generally quite significant that it might suggest perforation?
It's quite difficult to verbalize the answer, but with a bit of experience, you can tend to differentiate between a truly peritonitic abdomen and somebody that's just clenching. But it is difficult in a child, and a lot of children, for various reasons, just don't like being in hospital, don't like doctors, and don't let you examine. So with these patients, you can't really give them the benefit of the doubt. So if they come in with abdominal pain, then you might become more reliant on your investigations, like your blood tests, or asking them to do some crude examination like jumping up and down, if they're unwilling for you to touch their abdomen.
Yeah, okay, that kind of covers it. Yeah, it's okay.
Yeah, I think that the patients can voluntarily clench their abdomen, and this can be very difficult to differentiate, especially if they're agitated. So I think you have to rely on other parts of investigation to try and work out what's going on. But if in doubt, the safest thing to do is to keep them in hospital. So imaging generally isn't useful in acute appendicitis. So if you suspect that they have got a perforation, then it can be useful to get a CT scan. But other than that, there's no imaging modality which can reliably show appendicitis. So even a CT scan, which is apparently normal, doesn't exclude the diagnosis. So if the surgical team are clinically very concerned for appendicitis, essentially they have to take the patient to the theatre and have a look and try and locate the appendix. So next going to move on to ectopic pregnancy, which, as mentioned, is the most worrying gynecological cause of acute abdominal pain. So any female with acute abdominal pain has an ectopic pregnancy until proven otherwise. And this is defined as any pregnancy outside of the uterus. And the most common place for this to occur is in the fallopian tubes, but it can also occur in the ovary or in the abdomen. And it classically presents with severe lower abdominal pain. The patient may be shocked and they may have left shoulder tip pain. This is because of diaphragmatic irritation. So if blood touches the diaphragm, then you can find this symptom. You tend not to get right shoulder tip pain because the liver is protective of this side of the diaphragm. So as mentioned, you need to do a HCG in all females of childbearing age. Pelvic exam can be useful, and if the patient is unstable, then we can do a fast scan in A&E. So this is where we look for free fluid with the abdomen, which in this case is presumed to be blood. If you've got the appropriate personnel around, then you can get a pelvic and transvaginal ultrasound, which is even more useful. So with these imaging modalities, you may be able to see the ectopic within the tube, for example. If the patient is stable, then they're referred to the obs and gynae team. Well, they are regardless, but if they're stable, then the team will perform serial HCGs. So I think as a general rule, if the beta HCG level increases by less than 60% over a 48-hour period in early pregnancy, this is quite suspicious for ectopic. So it should be doubling over that time period. And if it's increasing at a slower rate, this suggests that the pregnancy is kind of being stifled by being in a like the fallopian tubes where the pregnancy can't grow at a normal rate. In terms of management, there are three main options. So if the patient is stable, and especially if their HCG level is falling, then this can be managed conservatively with a kind of watch and wait approach. There's medical management, again, for patients who are stable. So with this, methotrexate, which you'll know is an antifolate drug, stops the embryo from growing. And the surgical option, which is used for unstable patients, if the fetus is in the fallopian tubes, this is a salpingectomy. This is a life-saving surgery, so this is only reserved for patients who are very unwell, and there's obviously future potential implications for fertility after taking one of the fallopian tubes out. The risk factors for ectopic pregnancy are fairly obvious in the sense that they're all things which mean that the fallopian tubes might behave in an abnormal way. So if the patient's had a previous ectopic, if the patient's got a history of pelvic inflammatory disease, or if they've had previous surgery to their tubes for some reason, maybe they've got a history of endometriosis. These are all risk factors. So they're important things to specifically ask about if you're considering this diagnosis. So we're going to move on to PR bleeding. So just splitting this into two main types. There's fresh bleeding, which is where the blood is red, the same as if you cut your finger. And then there's melena, which is a black tarry-like stool, which smells very offensive. It's quite easy to differentiate between the two, not just as a medical professional, but just when you're speaking to the patient, because I've seen melena enough times, and the patient will know if they've got melena. It's very abnormal, and the smell is horrific. So there shouldn't be, it shouldn't be clinically too difficult to differentiate between a fresh bleed and melena. So causes of fresh PR bleeds include hemorrhoids and anal fissures, both of which generally aren't too worrying. And then there's more concerning things like malignancy, and then things that potentially fall in between the two. So diverticular disease, inflammatory bowel disease, angiodysplasia. I've put severe upper GI bleed here, which can cause fresh PR bleeding. If the blood in the upper GI tract is really brisk and really heavy, it rushes through your system so quickly that it doesn't become melena like you'd expect with most upper GI bleeds. But in this instance, the patient's bleeding so heavily that they'll be really acutely unwell. So this should only be considered really if a patient is really unwell and in hypovolemic shock. And melena, as mentioned, is due to upper GI bleeding. So a PR exam is really useful. So even if you've been able to differentiate between a fresh bleed and melena, it also gives you more information. So you may be able to see external hemorrhoids. You may be able to see an anal fissure, which essentially is a cut in the anus, often preceded with a history of constipation. So the patient's been straining a lot, and then this causes a small tear which can bleed. The PR may reveal a rectal mass, for example, which is suspicious for malignancy and obviously warrants further follow-up. If the patient is unstable, they need 2 big cannulae and the usual bloods for this situation. If the patient is stable, then the investigation of choice for lower GI bleed is a CT angiogram. The management of upper GI bleed, I think we've already covered on the peptic ulcer slide. The management of hemorrhoids and anal fissures tends to be conservative unless the hemorrhoids are thrombosed. Sometimes these are managed with topical treatment like topical GTN, and the patient may need to be followed up with their GP. Severe lower GI bleeds are referred to the surgical team, and these are managed either with surgery or with angioembolization. So this is done by the interventional radiologist. But regardless, these patients initially need to be kept under the care of the surgical team. And I think this is the last pathology to cover. So this is abdominal trauma. So this is a really big topic. And I've been asked to cover just hemodynamically stable patients. And even then, this is a very kind of brief overview because, as you can expect, the topic is quite huge. But just some brief important information. The liver and the spleen are the most commonly injured organs from blunt trauma. And if a patient's got fractures of their right or their left lower ribs, so these generally means ribs 10, 11 or 12, then you need to exclude injury to the underlying structures, i.e. the liver or the spleen. So liver injury causes right upper quadrant pain, and they might have shoulder tip pain if there's diaphragmatic irritation. Spleen injury causes left upper quadrant pain, and again, they might have shoulder tip pain, which is known as Kerr's sign. Renal injury often results in hematuria. So in almost 90% of patients with blunt renal injury, they have hematuria, but this might be microscopic. You also need to examine the patient and look for flank pain and bruising. And in terms of your investigations, like I say, if you suspect a renal injury, then it's essential to do a urine dip and look for hematuria. If the patient's stable, then they need a CT scan. And if you're suspecting vascular injury, then this needs to be done with contrast. So for liver, spleen and renal injuries, there's a grading system, which I don't think you need to know much about, and I don't know much about. I think this is more of a surgical specialized bit of information, but there's grading called AAST, and this grades all of these injuries on a scale of 1 to 5, 5 being the most severe. And this is often done upon imaging. So when you get your CT scan done and when it's reported by a radiologist, the radiologist will likely say, for example, there's a laceration of the liver, and this appears to be in keeping with a grade 4 injury. And this is useful for the surgical team because both the hemodynamic status of the patient and the grading of the injury determines whether the patient is suitable for observation or whether they need to go for surgical intervention. One thing to note with surgery for splenic injury is most of these patients end up having a splenectomy. And if this is what's needed, then it's life-saving. There isn't much that can be done about that, but it's done as a last resort because this renders the patient immunocompromised for life. So I think we're coming to about an hour at the end of the talk here. So thank you very much for listening. What I will do is I will hand the screen back to Selena, and if anybody's got any questions, then please feel free to unmute your mics and ask, or I can have a look in the chat if anybody's asked any questions in there. So let me try and stop sharing.
Dr. Foster, Tanisha, I believe you have a question.
Yes, hi, good afternoon.
Hello.
I know Dr. Stuart would have mentioned or spoke mostly about the ectopic pregnancy and appendicitis, right? And we know how these conditions can basically mimic each other. Now, I know you would have talked about the investigative tools to use as it relates to the ectopic pregnancy, which include the serial HCG and the transvaginal ultrasound. Now, as it relates to the appendicitis, I know you spoke mostly that it is a clinical one, right? So there basically no reliable imaging tool to use. Now, in that case, what would you say would be the most important interventional tool to use as it relates to a female patient that comes in with abdominal pain and your suspicion in that case, let me say, right, and ectopic pregnancy and appendicitis? Like, would you do a broad workup and you're doing all of these laboratory tests? Because I know it's a very emergent case that will require surgical intervention. So we don't want to go take out the pancreas, and then it's not the pancreas, then we have to go to the tubes. Like,
That's a really, really good question. And this is a situation that we have quite often actually, where we're unable to exclude a gynecological problem like an ectopic because the HCG is positive, but at the same time, that doesn't mean that it's an ectopic pregnancy, and there could well be an acute surgical problem like appendicitis. So the best thing to do in that situation is to treat the patient with your normal A to E approach if they're unwell, and speak to both of the teams. So you need to speak to your surgical team and your obs and gynae team, explain the situation, explain that your provisional diagnosis is either acute appendicitis or ectopic pregnancy, and get them both to come down. Because there are a few cases within medicine where, especially in the emergency department, because of limitation of how much time we have to see the patient, and there's some investigations that we're unable to do, or at the point of referral we haven't had the ability to do because of time. You just need to act in the most safe way possible. So in that situation, with a young female with acute, severe lower abdominal pain, with a positive HCG, if the HCG is negative, then it's not an ectopic, and that diagnosis is excluded. But with a positive HCG, then you need to get both teams to come and see the patient.
Okay, doctor, thank you so much for that explanation, and I'll definitely consider those parameters.
We often have a similar situation with patients that aren't acutely unwell. So with stable young female patients, where you're not considering a ruptured ectopic pregnancy, but it could be an ovarian pathology like a torsion or a cyst, we really commonly have this situation where we'll try and refer to the surgical team, and they say, I don't think this is for us, it sounds gynae. You speak to the gynae team and they say, how do you know this isn't appendicitis? I think as a general rule, once ectopic is excluded, the other gynae causes of abdominal pain don't tend to kill the patient. So if you've excluded an ectopic and you're unable to differentiate between gynae pathology and appendicitis, I would then refer to the surgical team. Once they're happy this isn't acute appendicitis, they can then speak to the gynae team, because this is the logical sequence of working through the things which will do the most harm to the patient.
Okay, doctor, thank you.
Right, so any more questions? Okay, well, thank you very much, Dr. Foster. That was a really useful lecture. And before you go, I'm going to put up the QR code and everything, but for everyone else who's still here, thank you so much for attending and have a nice evening.
Thank you. Bye. All right.
Bye.
Thank you.